Hi, my name is Amanda Nguyen, and I'm an oral medicine specialist in Perth, Western Australia. Today I'll be giving you a short tutorial on mouthwash use for salivary gland hypofunction and xerostomia. Before we get into discussion of the mouthwashes, here is some of the assumed knowledge. The differences between xerostomia and salivary gland hypofunction, how to assess these, what the different causes are, and the management principles. Patients should be aware of their increased caries risk, and discussion of a low carcinogenic diet, frequent dental visits, and use of a high fluoride toothpaste is important. Now let's talk about some of the symptomatic management options, including salivary substitutes and oral lubricants. Before we get into this, assessment and diagnosis before management is imperative. Management of hypersalivation and xerostomia may include stimulating saliva. Now, this is preferable where possible. However, it does depend on the body's residual capacity to produce saliva. For example, patients who have experienced head and neck radiotherapy may not be able to do so. The use of sialagogues is possible. This may include the use of pilocarpine eye drops or cevimeline, but that is not available in Australia. Saliva may be stimulated with mechanical means via chewing gum or sucking on a sugar-free low-acid candy. Through electrical means, so via electrostimulation, and examples of this include the Cellywell, Cellipen, and Generino devices. Symptomatic relief can be sought with ensuring adequate water intake and hydration, or the use of topical saliva substitutes or lubricants. It is important to modify the underlying disease or condition, and this may include liaising with the patient's medical practitioner about some medications that they are on, which may be related to the salivary gland hyperfunction, or other means of modifying the underlying disease process. Xerostomia is the chronic and subjective sensation of a dry mouth, as opposed to salivary gland hypofunction, in which there are objective signs. So xerostomia is a symptom which the patient will tell you about. It is a common problem, and it is estimated that about 30% of the population has experienced this. Xerostomia can significantly affect a patient's quality of life. The causes of xerostomia and or salivary gland hypofunction are numerous. This may include medications, head and neck irradiation, lifestyle factors such as caffeine intake or dehydration, systemic conditions including Sjogren's syndrome and type 2 diabetes, or it may be idiopathic. So here is a question for you. Can we cure xerostomia? I think this is quite an important point to make. We cannot cure xerostomia, and management is palliative. If I would like to recommend a topical therapy for my patient, is there a superior product? No, there is no one-size-fits-all product. There needs to be consideration of the patient's concerns, needs, and oral health state. There is a Cochrane review from 2011 by Furness et al., which states that there is no one topical therapy intervention for the management of dry mouth that is superior over another. I have another question here for you. What is the most commonly used home remedy for management of oral discomfort associated with xerostomia? If you thought back to slide 3 and said the answer was water, you are absolutely correct. It is water. Now, what other home remedies can you think of? Olive oil is something that a lot of people have in their pantries. Olive oil has inhibitory effects on carcinogenic bacterial growth, assists in controlling oral malodor, and can reduce tooth demineralization. It has olive polyphenols, which contributes to the modulation of oxidative balance and is considered safe at high levels. To top it all off, olive oil is low cost. Milk is something else that has the chemical and physical properties of a good saliva substitute. Besides the obvious benefit of providing moisture and lubrication for the dehydrated mucosa, milk also buffers oral acids, reduces enamel solubility, and contributes to enamel remineralization. These anti-carcinogenic factors are generally attributed to the high calcium and phosphate content, along with the milk phosphoproteins that strongly adsorb to enamel. Patients with xerostomia also have difficulty in obtaining proper nutrition due to problems with lubricating, masticating, tasting, and swallowing food. So milk can help with that. The Xerostom range of products is something that I've come across that does include olive oil. However, it is not easy to find in Australia. The range includes a toothpaste, mouth rinse, spray, and gel, and they contain 3 active ingredients: olive oil, betaine, and xylitol. Betaine is a naturally occurring amino acid and has been demonstrated to reduce skin irritating effects found typically in mouth products containing sodium lauryl sulfate, and betaine has been associated with improving symptoms of dry mouth. The olive oil has anti-inflammatory, antimicrobial, and oral lubricating properties, and the xylitol has anti-caries activity. This product has a neutral pH and a mild lemon aroma. So what other products are there available in Australia? I took a walk at my local supermarket and pharmacy to see what I could find.
So what other products are there?
There are many choices. I think broadly we can categorize these into saliva substitutes versus oral lubricants. Saliva substitutes incorporate antimicrobial agents and have some remineralizing and buffering capabilities. Oral lubricants typically provide only symptomatic management and offer little or no preventative properties. This is important because the oral manifestations secondary to xerostomia in patients with salivary gland hypofunction may include heightened rates of dental caries, periodontal disease, non-carious tooth loss, and oral infection. So you may have heard of the LP3 Protein Enzyme System. This system incorporates antimicrobials that are found naturally in human saliva. This includes lactoferrin, lysozyme, and lactoperoxidase. Lactoferrin binds iron, rendering it inaccessible to carcinogenic bacteria for growth, and hence lactoferrin functions as a bacteriostatic agent. Lysozyme, which is the same thing that is found in human tears, is a naturally occurring antibacterial, and it interferes with bacterial cell walls, resulting in cell death. Lactoperoxidase further controls bacterial levels by stimulating the production of hypothiocyanate, an effective antimicrobial that is naturally found in human saliva. This LP3 protein enzyme system has been utilized by several companies, including the makers of OralSeven and BioExtra.
So you may have heard of the LP.
So this is the OralSeven Moisturising Mouthwash. The range includes the mouthwash, mouth spray, mouth gel, and toothpaste. I found the range fairly easy to find in most of the pharmacies that I visited in Perth, Western Australia. Besides the LP3 protein enzyme system, the ingredients include aloe vera and peppermint oil. The toothpaste is fluoride containing. It has a neutral pH and is SLS, sugar, and alcohol free. The moisturizing mouthwash comes in 2 sizes.
So this is the OralSeven moisturizer.
OralSeven has also recently released chewing gum, and I bought some to try for myself. It has a mild flavor that was fairly pleasant and includes xylitol and lactoperoxidase. This is also widely available in most pharmacies that I visited.
OralSeven.
Another popular range of products for dry mouth is Biotin. Biotin products used to have a low pH in the range of 5 to 6. It was reformulated and now claims to have a more neutral pH, and this is about 6.5. However, with reformulation, the LP3 protein enzyme system that used to be available in the old formulation has since been removed.
Another popular.
I have included the ingredients of the Biotin mouthwash here for you to have a look, and it includes xylitol.
I have included the ingredients of
The mouthwashes that we discussed so far have hydroxyethyl cellulose as a base. This is a common chemical in pharmaceuticals as it adds high viscosity and functions as a suspension matrix. It is also commonly used in eye drops. In the context of mouthwashes, it mimics the properties of natural saliva. Other chemicals that do similar are carbamase, xanthan gum, and cellulose gum.
The mouth
Another common base is carboxymethylcellulose, or CMC. CMC is water soluble, which is why the duration of action is limited and frequent use is required.
Another
Colgate Dry Mouth Relief is a CMC-based mouthwash. Other chemicals to add viscosity to the mouthwash include propylene glycol and xanthan gum. This dry mouth relief mouthwash is fluoride containing, alcohol free, SLS free, and contains CPC, which has plaque inhibition properties. The pH of this product is 5.8. This is another fairly popular product, the GC Dry Mouth Gel. This only comes in gel form and not as mouthwash.
This is another popular product, the GC Dry Mouth Gel. This is an
So the GC Dry Mouth Gel is CMC based. Other chemicals include carrageenan and polyglycerol. If you like cooking and molecular gastronomy like I do, carrageenan and xanthan gum may be familiar to you because they use as thickening agents. But that's by the by. So the GC Dry Mouth Gel also includes sodium citrate, but it claims to be neutral. It claims to be pH neutral. It is alcohol, SLS, and sugar free. It does not contain fluoride or any other remineralizing agents. The company does claim that the gel lasts for up to 4 hours.
so the GC
So this is neither a mouthwash or a mouth gel. However, I do find this useful in certain patients. These are called Xylem melts and they're oral adhering tablets. So you can put them in the oral cavity, usually in the buccal sulcus, and it slowly dissolves and releases xylitol and stimulates saliva. The agent in this Xylem melt is cellulose gum. It is especially useful for someone to use overnight.
So this is neither a mouth
To finish off, I got a couple more questions for you. So the first one is, would you recommend tooth mousse?
To finish off, I've got a couple.
You can, as the flavor of the tooth mousse may help stimulate saliva flow. Tooth mousse comes in a lot of different flavors, same as the GC Dry Mouth Gel. However, saliva will enhance the effectiveness of CPP-ACP. So before recommending tooth mousse, I would want to make sure that the patient does have enough saliva for tooth mousse to be the most effective.
You can.
So after all that, what is the best management option for a patient with xerostomia? So it's back to basic principles, investigating the cause, making sure you have the right diagnosis, addressing simple things like hydration and lifestyle for the patient. And if the management is symptomatic, the focus needs to be on the prevention of the consequences of salivary hypofunction. Thank you.
So it's back to basic principles, investigating the cause, making sure you have the right diagnosis, addressing simple things like hydration and lifestyle for the patient. And if the management is symptomatic, the focus needs to be on the prevention of the consequences of salivary hypofunction. Thank you. All that. What is the best management option for a patient with xerostomia? As the flavor of the tooth mousse may help stimulate saliva flow. Tooth mousse comes in a lot of different flavors, same as the GC Dry Mouth Gel. However, saliva will enhance the effectiveness of CPP-ACP. So before recommending tooth mousse, I would want to make sure that the patient does have enough saliva for tooth mousse to be the most effective. A couple more questions for you. So the first one is, would you recommend tooth mousse, wash, or a mouth gel? However, I do find this useful in certain patients. These are called Xylem melts and they're oral adhering tablets. So you can put them in the oral cavity, usually in the buccal sulcus, and it slowly dissolves and releases xylitol and stimulates saliva. The agent in this Xylem melt is cellulose gum. It is especially useful for someone to use overnight. The dry mouth gel is CMC based. Other chemicals include carrageenan and polyglycerol. If you like cooking in molecular gastronomy like I do, carrageenan and xanthan gum may be familiar to you because they use these thickening agents, but that's by the by. So the GC dry mouth gel also includes sodium citrate, but it claims to be neutral. It claims to be pH neutral. It is alcohol, SLS, and sugar free. It does not contain fluoride or any other remineralizing agents. The company does claim that the gel lasts for up to 4 hours. Another fairly popular product, the GC dry mouth gel. This only comes in the gel form and not as a mouthwash. Colgate Dry Mouth Relief is a CMC-based mouthwash. Other chemicals to add viscosity to the mouthwash include propylene glycol and xanthan gum. This dry mouth relief mouthwash is fluoride containing, alcohol free, SLS free, and contains CPC, which has plaque inhibition properties. The pH of this product is 5.8. Common base is carboxymethyl cellulose, or CMC. CMC is water soluble, which is why the duration of action is limited and frequent use is required. Mouthwashes that we discussed so far have hydroxyethyl cellulose as a base. This is a common chemical in pharmaceuticals as it adds high viscosity and functions as a suspension matrix. It is also commonly used in eye drops. In the context of mouthwashes, it mimics the properties of natural saliva. Other chemicals that do similar are carbamers, xanthan gum, and cellulose gum. Biotin mouthwash here for you to have a look, and it includes xylitol. Range of products for dry mouth is Biotin. Biotin products used to have a low pH in the range of 5 to 6. It was reformulated and now claims to have a more neutral pH, and this is about 6.5. However, with reformulation, the LP3 Protein Enzyme System that used to be available in the old formulation has since been removed. OralSeven has also recently released chewing gum, and I bought some to try for myself. It has a mild flavor that was fairly pleasant and includes xylitol and lactoperoxidase. This is also widely available in most pharmacies that I visited. Mouthwash. The range includes the mouthwash, mouth spray, mouth gel, and toothpaste. I found the range fairly easy to find in most of the pharmacies that I visited in Perth, Western Australia. Besides the LP3 Protein Enzyme System, the ingredients include aloe vera and peppermint oil. The toothpaste is fluoride containing. It has a neutral pH and is SLS, sugar, and alcohol free. The moisturizing mouthwash comes in 2 sizes. LP3 Protein Enzyme System. This system incorporates antimicrobials that are found naturally in human saliva. This includes lactoferrin, lysozyme, and lactoperoxidase. Lactoferrin binds iron, rendering it inaccessible to carcinogenic bacteria for growth, and hence lactoferrin functions as a bacteriostatic agent. Lysozyme, which is the same thing that is found in human tears, is a naturally occurring antibacterial, and it interferes with bacterial cell walls, resulting in cell death. Lactoperoxidase further controls bacterial levels by stimulating the production of hypothiocyanate, an effective antimicrobial that is naturally found in human saliva. This LP3 protein enzyme system has been utilized by several companies, including the makers of OralSeven and Biotin. There are many choices. I think broadly we can categorize these into saliva substitutes versus oral lubricants. Saliva substitutes incorporate antimicrobial agents and have some remineralizing and buffering capabilities. Oral lubricants typically provide only symptomatic management and offer little or no preventative properties. This is important because the oral manifestations secondary to xerostomia in patients with salivary gland hypofunction may include heightened rates of dental caries, periodontal disease, non-carious tooth loss, and oral infection. They're available in Australia. I took a walk at my local supermarket and pharmacy to see what I could find. The Xerostom range of products is something that I've come across that does include olive oil. However, it is not easy to find in Australia. The range includes a toothpaste, mouth rinse, spray, and gel, and they contain three active ingredients: olive oil, betaine, and xylitol. Betaine is a naturally occurring amino acid and has been demonstrated to reduce skin irritating effects found typically in mouth products containing sodium lauryl sulfate, and betaine has been associated with improving symptoms of dry mouth. The olive oil has anti-inflammatory, antimicrobial, and oral lubricating properties, and the xylitol has anti-caries activity. This product has a neutral pH and a mild lemon aroma. Milk is something else that has the chemical and physical properties of a good saliva substitute. Besides the obvious benefit of providing moisture and lubrication for the dehydrated mucosa, milk also buffers oral acids, reduces enamel solubility, and contributes to enamel remineralization. These anti-carcinogenic factors are generally attributed to the high calcium and phosphate content, along with the milk phosphoproteins that strongly adsorb to enamel. Patients with xerostomia also have difficulty in obtaining proper nutrition due to problems with lubricating, masticating, tasting, and swallowing food, so milk can help with that. And a lot of people have in their pantries. Olive oil has inhibitory effects on chirogenic bacterial growth, assists in controlling oral malodor, and can reduce tooth demineralization. It has olive polyphenols, which contributes to the modulation of oxidative balance and is considered safe at high levels. To top it all off, olive oil is low cost. If you thought back to slide 3 and said the answer was water, you are absolutely correct. It is water. Now, what other home remedies can you think of? I have another question here for you. What is the most commonly used home remedy for management of oral discomfort associated with xerostomia? No, there is no one-size-fits-all product. There needs to be consideration of the patient's concerns, needs, and oral health state. There is a Cochrane review from 2011 by Furness et al., which states that there is no one topical therapy intervention for the management of dry mouth that is superior over another. If I would like to recommend a topical therapy for my patient, is there a superior product? I think this is quite an important point to make. We cannot cure xerostomia, and management is palliative. Here is a question for you. Can we cure xerostomia? Is the chronic and subjective sensation of a dry mouth, as opposed to salivary gland hypofunction, in which there are objective signs. So xerostomia is a symptom which the patient will tell you about. It is a common problem, and it is estimated that about 30% of the population has experienced this. Xerostomia can significantly affect a patient's quality of life. The causes of xerostomia and or salivary gland hypofunction are numerous. This may include medications, head and neck irradiation, lifestyle factors such as caffeine intake or dehydration, systemic conditions including Sjogren's syndrome and type 2 diabetes, or it may be idiopathic. Assessment and diagnosis before management is imperative. Management of hypersalivation and xerostomia may include stimulating saliva. Now, this is preferable where possible. However, it does depend on the body's residual capacity to produce saliva. For example, patients who have experienced head and neck radiotherapy may not be able to do so. The use of sialagogues is possible. This may include the use of pilocarpine eye drops or cevimeline, but that is not available in Australia. Saliva may be stimulated with mechanical means via chewing gum or sucking on a sugar-free, low-acid candy. Through electrical means, so via electrostimulation, and examples of this include the Salivary Pen and Genarino devices. Symptomatic relief can be sought with ensuring adequate water intake and hydration, or the use of topical saliva substitutes or lubricants. It is important to modify the underlying disease or condition, and this may include liaising with the patient's medical practitioner about some medications that they are on, which may be related to the salivary gland hypofunction, or other means of modifying the underlying disease process. discussion of the mouthwashes, here is some of the assumed knowledge. The differences between xerostomia and salivary gland hypofunction, how to assess these, what the different causes are, and the management principles. Patients should be aware of their increased caries risk, and discussion of a low carcinogenic diet, frequent dental visits, and use of a high fluoride toothpaste is important. Now let's talk about some of the symptomatic management options, including salivary substitutes and oral lubricants. Hi, my name is Amanda Nguyen, and I'm an oral medicine specialist in Perth, Western Australia. Today I'll be giving you a short tutorial on mouthwash use for salivary gland hypofunction and xerostomia.